All right, let's switch gears. Let's start talking about peripheral or vascular diseases. Okay. So, it's going to be a group of disorders. Some reason or another, it's altering our blood flow, so we're not able to just have that nice continuous perfusion like we should. For some reason, it's alternating the way our blood flows. Okay. Whether that be from plaque buildup, some kind of atherosclerosis, maybe some type of clot, some type of trauma, something like that is altering the way our blood flows. Okay? If we have a diagnosis of peripheral vascular disease, we're pretty much going to assume that we have some type of venous disease or peripheral arterial disease. Okay? They're all kind of lumped up into one. They have some key differences, and that's how you're going to kind of distinguish between PAD or peripheral arterial disease versus your peripheral venous disease. Okay. Alright, so now nice looking feet here. So with peripheral arterial disease, we have that narrowing or almost complete occlusion of that artery that's having that blood supply to our feet, okay? And so it's really affecting our extremities on this. Our key signs and symptoms are going to be your hair loss, okay? You're going to start to notice that your patients just don't have any hair on their foot. Most people are going to have hair on their foot. If they don't shave it, it's going to get real long, okay? You're going to see hair on somebody's foot. Okay? Mostly for men, I guess. Women, okay? Caroline doesn't have hairy feet. So most men are going to have hairy feet, okay? So they're going to start having some loss of hair. They're going to start getting these nasty, crusty looking toenails right here. So yeah, they're kind of yellowish, brownish looking color, okay? There's not enough good blood supply to promote that healthy toenail growth, okay? So we kind of get this cruddy mess that's not able to be pushed out from new toenail growth, okay? All right, we have different stages of peripheral arterial disease. We have stage 1 through stage 4. Stage 2 is when your patients are going to start to complain about something, okay? That's when they're going to come and seek some kind of medical attention when they go to their primary health care provider. They start complaining, as what we call it, is claudication, okay? Claudication. Grandpa goes out to the mailbox. As he gets to the mailbox, his legs start to hurt. His calves start to kind of cramp up. He has this sudden onset of pain, okay? He sits down in his chair because he has a chair next to the mailbox. The pain goes away very shortly. As soon as he gets back up, he starts walking back to the house. He starts to have pain again, okay? So intermittent claudication is just kind of intermittent pain that your patients will start to develop, okay? As your peripheral arterial disease starts to progress further and further, they're going to have persistent and more constant pain than previously, okay? And then they'll start to even have it at rest. Once they start taking a seat, they'll even have it throughout the whole time as well. So as they're walking around or taking a seat, okay? And then with stage 4, we can start to have necrosis, so start having some of those dying off toes, have to start developing ulcers, things like that. Okay. I've even taken patient socks off before and their big toe just like falls off. And then you just hand it to them a little cup and say, "Here's your souvenir."
How do you tell the difference, like, between like a diabetic patient if they're having this or just diabetic feet?
Get there just sick.
We had someone's fingernail come off when we were doing a dressing change at the hospital.
So what came off?
Fingernail.
Fingernail. So if you look to the left right here, this is what we call dependent rhubarb as well. And so just the coloration difference, all right? So patients are dangling feet, and then when you elevate it, you kind of get this nice purpley color, and that's what we see. Okay? All right. So to differentiate, to talk about what Natalie was saying, page 738 in your med-surg book, the big orange book, y'all have that? Box 30.7. It differentiates our arterial ulcers from our venous ulcers from our diabetic ulcers, okay? So box 30.7, page 738, there's some nice graphics in there. And it's probably the same graphics, honestly, I probably stole them from the book. But, with your arterial ulcer development, we have a nice, well-defined wound, okay? Usually it's gonna be on the ends of your toes, and sometimes it's kind of in the cracks of your toes, okay? Compared to your other ulcers. See how this one has kind of just jagged edges right there? That's how we know that it's a venous ulcer, okay? So your arterial ulcers are gonna have these nice, well-defined wound edges, okay? That's because the blood is kind of pulling up, or not getting enough blood flow to that limb right there, to that foot, okay? Definitely gonna have a lot of pain as well, versus your venous ones, okay? So this is when we're starting to have that pulling of the blood within your foot, okay? Really, really jagged edges, it's poorly defined, just this kind of nasty chronic ulcer that kind of just sticks around, okay? So, arterial, our problem is gonna be getting the blood flow to that limb, all right? So that atherosclerosis, or that plaque buildup, is not allowing that blood flow to occur, not allowing to get that nice oxygen to those toes and those fingers, and that's how we start to develop some of that necrotic tissue, dying off tissue. With our venous, we have the reverse effects, okay? So the blood sits there in pools and is not allowed to kind of pump back up to the heart to get recirculated through, to get reoxygenated, so we can supply more oxygen to those areas, okay? We have the faulty valves within those veins that's not able to push that blood back up to where we need it to go, okay? So what do we need to teach our patients? Make a picture, let's see. So if our patients have peripheral arterial disease, we're gonna think about the A in arterial, okay? So they need to dangle their feet. Okay? And that's gonna help reduce our pain, some of that intermittent provocation, okay? Trying to allow gravity to hopefully push down some of that blood to get it circulated into some of those extremities, okay? So we're trying to get that blood flow to circulate down. Okay? With peripheral venous disease, there's a V in there, okay? So we want our feet up in the air instead, okay? Please don't judge my drawings, but, all right, it works. So we want to elevate our feet. That's how we want to think about it, okay? So we're trying to promote and encourage the blood to flow back to central circulation, okay? So we're trying to allow gravity to push the blood flow back up, okay? What's the fun?
It's reverse trendillion.
Yeah. So, anyway, that's how I think about it. Or if you just have an A and then a V with your fingers, you can think about it that way too. What's the Usher song? A-Town?
Please up.
Yeah, there you
And
go.
I was.
That's the song. There you go.
I know, but I told you this yesterday, that I got from TikTok, so I told you TikTok is very helpful.
Okay, does everybody understand the arterial versus the venous and how we're gonna educate them? Yes, okay. Other things we can think about or consider. Try to avoid some type of injury to the feet at all costs. At a certain point, they're gonna start getting some neuropathy in their feet as well. They're gonna start not be able to feel their feet at all. So we have to really encourage our patients to limit the possibility for injury. I've had a patient come in before and they had a uncooked piece of macaroni stuck in the bottom of their foot because they couldn't feel it, okay? And they pull it out and they had this just nice big ulcer down there, okay? So we have to encourage our patients to inspect those feet daily to make sure they don't have some type of injury, okay? Make sure that they wear the proper footwear, okay? If you can't feel your feet, how do you know what size shoe you need, all right? Is it too tight or too loose, okay? So they need to consider those things. Maybe get someone else's second opinion to allow them to kind of put on some shoes and see what works for them, okay? Keep your toenails clean, filed. We're not really allowed to cut toenails in the hospital because it can introduce some type of sore or some kind of skin tear, all right? So maybe encourage our patients to go to a podiatrist, someone that specializes in just working with feet, taking care of feet, all right? They're especially trained to cut fingernails and toenails, so, okay? Again, inspect their feet daily, so even if they have like a stand-up mirror and they can sit on the edge of the bed and kind of raise their foot up a little bit so they can see the bottom of their foot, or they have one of the little makeup mirrors and they can kind of scan the bottom of their foot, all right? So kind of keep that at the bedside. So every day they'll look at their feet, make sure there's no type of wound there, okay? We can also encourage them to wear white cotton socks. Why cotton socks?
So it's easier to see.
You can easier see blood, okay? So that's pretty a simple fix. If you have white socks, you can see that blood, all right? Let's see. Patient education, this box is also on page 743 of your med surg book, the orange book. It's box 30.9. Another big one with these folks is keeping them away from extreme temperatures, so like not getting in a hot tub or a real burning bath, okay? They can't feel their feet, so they don't know if it's hot or not anyway, all right? And then we get hot for like a 1st-degree burn just from the water, okay? All right. So when we have peripheral arterial disease, we can actually develop even a more severe complication from this. What's an occlusion? So a complete block off of that artery. Some type of clot or enough plaque buildup has occurred where we get an occlusion, okay? With occlusion, we're gonna assess the 6 Ps, okay? So pain's gonna be your first P. It's gonna be pretty painful if they have no blood flow at all to their foot, all right? Pallor, or their color. What type of color are we gonna see? All right, so we're not gonna see the nice pink, healthy tissue of normal circulation. More of a cyanotic, purplish type tint to their feet. Okay. Pulselessness. Are we able to feel a pulse at all? So for instance, the patient Sam had the other day, I think it was, were you able to feel a pulse in their foot?
No, I did it.
How to get a Doppler, okay? Don't go in your room and say, I think he has a pulse, or was that my finger's pulse? Who knows? And then just walk out 4 hours later, okay? Let's probably check on that, make sure. All right, so let's pick up that Doppler and be a good nurse and actually listen to hear if we hear a pulse, okay? If we don't hear a pulse, let's let somebody know, okay? Don't chart absent all night on your patient's pulses and then just go home, okay? Probably a bad idea, unless the patient or doctor already knows it, okay? So if the physician's already aware, then that's one thing, okay? Paresthesia, what's that? Anybody know? It's not on the board. Numbness, all right, tingling, numbness and tingling. So when you sit on your foot for a long period of time and then you get up and it feels all numb and wiggly, and then the blood starts to circulate back through, you get that nice tingly, sharp, stabby feeling. You know what I'm talking about?
Where you're like, don't touch my foot, but your kids touch it anyway.
Yeah, okay, so that's your paresthesia. Paralysis, so you can't really move your foot, have limited range of motion with your foot. And the last one for your 6 Ps is your poikilothermia.
Can you spell that for Chuck?
Poikilothermia, okay?
It's all about temperature.
Poikilothermia, Poikilothermia, okay? So coolness. Why we couldn't just say cold, I don't know.
Right.
But we can't say 5 Ps plus a C, so 6 Ps, alright? But it's more than just about your patient's limb being cold. It's the ability to kind of regulate that temperature, right? So that blood flow in and out helps us regulate our extremities temperature, okay? So now it starts to become just the temperature in the room, so just kind of room temp, okay? So it is about that coolness factor with that, okay? Let's see, blocked areas with that, we talked about Doppler already. All right, so now we gotta talk about what are we gonna do if we have an occlusion, okay? we let the physician know, he's gonna start ordering a bunch of stuff and you're about to get real busy, okay? So we have a couple of options. So the non-surgical options are gonna be more, before this occurs, okay? Before the occlusion actually happens, all right? You don't wanna have an occluded vessel and be like, all right, let's change your lifestyle, I'll see you back in 6 weeks, okay? You can't tell them to limit their caffeine when they already have an occlusion, so. So those lifestyle modifications are gonna be before the event occurs. So if they're at a higher risk, they eat a lot of fried foods, they're stressed, they are a smoker, they have limited mobility. Anybody with already diagnosed peripheral arterial disease gonna be at a higher risk. I don't know if I said immobility, but I'm gonna say it again. All right, so your patients that are laying in the bed all day, every day, and we go in there and most of your patients are getting what? What shot are we giving the love handles? Lovenox for the low weight heparin, okay? That's why they're getting it, because they're immobile. All right, we're trying to reduce the incidence of blood clots from forming, okay? We want to encourage our patients to not cross their legs. That's another good lifestyle modification, okay? Because that promotes for that blood just to kind of pull up in the extremities, okay? And when blood pools, it starts to clot, all right? So, then we can move on to some more non-invasive surgical management. So this can also occur with a blood clot, or right before blood clot occurs. Hopefully we can get some non-invasive surgical management first and prevent this from occurring, okay? So we have what's called a balloon angioplasty, okay? I think I got a picture of it. Yep, I do. So, they go in through the groin, so usually right there in the femoral artery. Yeah, this one's on here, I just added this one. Go in through the femoral artery, and they take this catheter, and it's like a huge catheter. I mean, it's like the size of an expo marker or bigger. I mean, it's a big old thing. Okay? Pretty impressive that they can actually thread that through there, okay? So they'll thread it through, and then they also have somebody from X-ray, and they'll actually shoot like dye in there and kind of see where that blockage is at, okay? Shoot an X-ray, sometimes it's continuous, and you can actually kind of see where the blood flow occurs, right? Wherever it stops, that's where we know we kind of need to inflate it more, all right? So they'll come in and they'll shoot air actually through, and it kind of compresses that plaque buildup against the arterial wall, so it kind of opens it up, balloons it open, so allow that blood flow to reopen, to get going. Okay. We also have what's called an atherectomy as well, which is part of the non-invasive process. Okay. Again, they're going to go through the femoral artery most of the time. And has anybody seen a roto-rooter?
Yep.
What a roto-rooter is, so it goes down the sink, roots out your pipes, has a little circulation, and it circulates and kind of rotates around. We're roto-rooting our arteries at this point, okay? That's our atherectomy. So they'll put this catheter device in, nice big device again, okay? At the very end of it, it's kind of got like a boat propeller motor on it, circulates real fast and kind of just grinds off like a Dremel almost, kind of grinding off some of that excess plaque buildup. Okay? Pretty cool stuff. So.
Are they away from these?
No.
Oh, that is it.
They're a little bit sedated. Yeah. You can just, when they're propofol, they're out, you're not gonna know it. I don't know it.
Don't worry about that.
They can, and usually there's some kind of suction in there. Sucks it up. Okay. So, what's our biggest risk right here? Bleeding out. Good. Okay. So, whether they rupture an artery, probably not a good idea. Okay, if they nick something going in, your femoral artery is one of the biggest arteries in your body, besides like your aorta. Okay, so if you nick that and that starts bleeding, that's probably an issue. Okay, or if they pull out, then you have somebody what's called a hold team, or it's just a good old-fashioned nurse that's got to hold pressure on the point of insertion. Okay, so imagine one of your biggest arteries in your body, and it has a catheter that's something bigger than this expo marker going in. It's going to cause a pretty big hole within your femoral artery, okay? So when you pull it out, it just squirts everywhere, all right? So you're gonna have to hold a lot of pressure. So you're in there for 45 minutes to an hour or more, holding direct pressure, manual pressure, within this site. There is some devices and stuff that, some like balloons and stuff that you can blow up, some sandbags that you can, put and kind of hold, pressure. Physicians don't really care for it. They like the old school method of just you sitting there holding direct pressure, because you can control the fluctuations of the pressure and really know exactly where you're pressing, okay? So bleeding is gonna be our biggest risk factor, and something we need to educate our patients on, okay? So if you're holding for 45 minutes, you need to make sure all your other patients are taken care of first, probably, right? Make sure all their meds are given. Then you also need to let somebody know, hey, I'm gonna be in this room for a while. Can you listen out for me? And then if I call out for help, can you come in here and assist me, okay? Usually you want all your supplies and stuff with you in case something happens, okay? And then, have the call light readily available, okay? So if you need some emergency situation or something, you can pull the call light out of the wall, or you can hit the nurse button, and hopefully somebody will show up at some point, okay? So, one of the horror stories of mine is, I had a patient had one of these, so I took the catheter out, held pressure for about 45 minutes to an hour, closer to an hour, so I thought I was good. So I put a big, heavy, pressure dressing on it, went to do my charting and stuff, and then all of a sudden my blood pressure just plummets, heart rate sky high, and I was like, dang, what's going on? And I thought it was just the machine acting funny, and I didn't think it was real. And then I uncovered the sheets, and there's just blood, just a huge pool of blood, so he's bleeding out in the bed, okay? So you hold manual pressure again, you call for help, and so I held pressure for another 45 minutes, and then he was fine after that, gave him a couple minutes of blood, but that's kind of worst case scenario. But yeah. Okay. So that addresses our non-surgical. It kind of sounds surgical, but more than non-invasive. It's really just kind of going in the groin, so it's not quite as intense as, say, your surgical management. I know it sounds like a lot, Meredith.
That's what I'm saying.
Compared
But you have a chance of bleeding out.
Compared
It's like not-
compared to cutting you
You may
open.
not, but.
compared to you cutting you open all the way, like our surgical management, we, it's gonna be a little more invasive, okay? So with surgical management, we're gonna try, for some arterial revascularization. We basically are just gonna bypass whatever's blocked, okay? So the best way to explain it is gonna be right here. Okay? So we take the greater saphenous vein, because it's one of a nice big juicy vein, okay? It's kind of the inside of your thigh, if you look at it that way, all right? And then we're gonna attach it to your femoral artery, just above where the blockage is, all right? And then we're gonna bypass the block and reattach it on the other side where the blockage no longer is, okay? And at that point, this artery, this little section or piece is no longer in use, okay? It's gonna go through the saphenous vein. Now, we really have to consider what type of patients that we can use this for, okay? If they already have bad perfusion or some kind of atherosclerosis already, are they able to kind of sacrifice that saphenous vein? Do they have adequate kind of blood flow? If they're not able to, we may not be able to take that saphenous vein. Maybe we'll have to look at the other leg. But are we going to risk the blood flow to that leg to save the other leg, okay? So we have to really make sure we're able to use that vein appropriately. Again, patient education is huge for this one, all right? Bleeding is gonna be one of your biggest risk factors with this. We need to educate our patients about that. We also need to educate them about them laying flat in the bed, okay? So if I held pressure for 45 minutes after pulling out a big pipe from their leg, do I need them out there doing kicks and flips and whatever, okay? They don't need to be out there doing the conga line or whatever. What's the people at the parade? Anybody know what I'm talking about?
Yeah.
The girls that kick the Rockettes, yes. The Rockettes, they don't need to be doing the Rockette kicks, okay? They need to be as flat as possible, all right? They don't need any kind of leg movement. Usually your physician is gonna give you some type of order for bed rest. So they'll say after 4 hours, your bed rest is up, and then you can elevate the head of the bed 45 degrees. And then a couple hours later, then you can elevate it up a little bit further, okay? A lot of patients don't like laying flat. It's a lot of back pain, they have trouble, issues with breathing. They're just uncomfortable, they wanna move around, they've been laying on the table already for a while. They're awake now, they wanna get up and go, okay? They're hungry because they haven't eaten all day because they're supposed to have this procedure. Well, you can't eat laying flat, right?
No, good, right?
So you'll aspirate. So we can tilt the bed and maybe do some funny things, and so we can get them in a position where they can eat. So we can actually kind of turn a little bit, just get them to lay up just enough. We're still not bending at the waist, all right? But we're able to help them eat.
Thank you, Sam.
Oh, sorry.
So what about the Vasilic arm thing? What do you do for that then?
The Vasilic arm thing, we
Yeah.
usually don't go for that one.
Well, you said it's in the PowerPoint.
Is it? Where is it? Yeah, I mean, you can, typically they're not gonna use, they're gonna use the thermal one, but you can.
Right.
All I know is they take it one spot, where they have it. That's how you do it. Once you get into more of your specialty areas, then you'll start to kind of realize what they actually do. Alright. Good enough?
Sure.
Okay.
You're the one who put it in PowerPoint, experience.
Okay. All that fancy to say, statin drugs. Okay. So your reductase inhibitors.
Make you feel like crap.
That's where this happens, you should.
Okay, so let's all recite it together since we all know what statins do. What are we looking for? Signs and symptoms. Say it again.
Rhabdomyolysis and leg cramps.
Rhabdomyolysis, leg cramps. Good. That's what they're going to, most often report is when they start on a new statin drug, they're gonna report some type of leg cramp, okay? And then rhabdomyolysis, which is severe. What is rhabdomyolysis?
It's like the tearing or breaking down of the muscle.
Lysing of the muscle, breaking down, tearing of the muscle, some type of muscle injury, okay?
Why would we put somebody on like a statin drug for this if they're already have so much going on in their legs?
Because we wanna try to reduce that, plaque load, that's where we're going. There's a couple other drugs that we can choose from, but statins are one of those ones, you know.
How rare is rhabdomyolysis?
Pretty rare, but you can see it.
Do you have one, like you have enough, like if they start having leg cramps and you stop it, are you gonna stop the rhabdo or?
So just because you have leg cramps doesn't necessarily mean you're going into full-blown rhabdomyolysis, okay? Sometimes those leg cramps will go away after a while. Maybe you need to reduce the dose a little bit, or maybe take it every other day. Sometimes if you take atorvastatin, you have leg cramps, and then you take, say, rosuvastatin right there, then you won't have leg cramps, okay? So it's all about kind of playing with our meds, kind of getting a fine tune for that patient. And then sometimes they still complain about leg cramps because they saw it on TV and that's what their friend reported, so they think they have leg cramps as well. In reality, they don't have leg cramps. They're just making that stuff up. But we gotta listen to our patients and we just have to believe them, okay? So, really bad on our liver as well. Grapefruit juice, pretty much if you see grapefruit juice on a test, make sure that's the answer because grapefruit juice is pretty much wrong all the time for most drugs, okay? Just throwing that out there.
Thought that was the best test, appreciate it.
It's not on the test, but it's just good to know, so.
Well, bummer.
Okay. Antiplatelets. So things like your aspirins, okay? And then, let's see what else we have. Plavix as well, alright? So your, clopidogrel right there, alright? All of them are gonna end, you see your clopidogrel and your pursuogrel, so you have your grels right there for your antiplatelets, alright? We're trying to prevent some, type of clot events, whether that be stroke, or, sometimes you'll see after an MI, okay? to help reduce the chances of having another MI, okay? Natalie, what's that? What did you, that was having trouble with you?
What's that?
Myocardial infection.
I want you to know that I have had to write a paper on that today too, so I can.
So myocardial infarction. Then sometimes AFib, we'll give it for AFib patients as well. AFibs are at a higher risk for clots, right? Got that pooling in the blood within the atriums, so there's a higher risk of clots there, okay? We need to educate our patients about signs and symptoms of bleeding. Encourage them to hopefully kind of avoid things like high risk activities, make sure they don't bump into the bed or bump into the door frame, something like that, okay? Really for any of these antiplatelets and your heparin therapies, we're gonna encourage them to use maybe just an electric razor instead of like a straight razor, okay? Because there's less chance of them nicking their face, okay? Their face is really vascular, so they have a high chance of bleeding. Even the smallest little nick would just continue to speed to the point where they have to go to the hospital, okay? So that's some of our education piece right there.
That's what I'm saying, my bones are full.
I'm sweating, so it's a little warm.
You always say that.
Alright, deep vein thrombosis. DVT, okay? So, your patient is going to complain about unilateral leg pain, alright? Unilateral swelling, redness, erythema, a lot of pain on one side versus the other. So for instance, the right leg right here is gonna be all red, hot, inflamed versus the left leg, okay? Vircho's triad, that's kind of important. So, we have all three of these things right here. Your Vircho's triad right here. So endothelial injury, some type of trauma that has occurred to one of our veins or to some of our outer layers of our skin, so some of the deeper tissue of our skin. Venous stasis, or just kind of stagnant blood flow within our veins, okay? So, for instance, when you cross your legs, okay, so we have some of that venous stasis, lack of blood flow. If you fly on an airplane to say Hawaii or something, it's on like a 9-10 hour flight, and you don't get up and move around and walk around, that could occur, okay? I'm going to Uganda in the summer, that's like a 24-hour flight, okay? Probably need to get, yeah.
Okay, so if you're
How
going
long
to,
will you teach us?
if you're going to, and Fuller's gone, who's teaching us?
We're gone at separate weeks, guys.
I was gonna say, don't bring no stranger.
We gotta work out.
Why are you going to Uganda?
Mission trip, so.
Aww.
But
That's for all 24 hours, right?
it's a long trip, maybe not quite 24 hours, but it's close to it. And so maybe I need to take an aspirin or some kind of antiplatelet plus walk around, wear my compression socks.
You have some on right now.
I do. Maybe my leg got that hot.
Come on.
My wife is probably gonna make me walk around, alright? She's gonna poke me every so often and say, get up and walk around, because that's what she does. She takes care of me, so.
And she should.
She's gonna make me do my compression socks, she's gonna make me take that aspirin, things like that, okay? And then hypercoagulability. So the chances of our blood clotting up, okay? We have an increased chance of that. Our blood's real thick, so we're not on some type of blood thinner or antiplatelet, something like that. So we have a higher instance of developing clot. So that's called Vircho's triad, okay? When we have a deep vein thrombosis, or we develop one, we have an increased risk of stroke. Why would we have an increased risk of stroke if we have a clot in our leg?
High blood pressure.
Breaks off, goes to your vein, or to your brain. Breaks off, goes to your brain, okay? Same thing with an MI, okay? So it breaks off from your leg, floats up, and then gets lodged into your coronary arteries, okay? Pulmonary embolism, or PE, same thing. Breaks off, travels, and then it gets lodged into one of your smaller vessels within your lungs, okay? Then you get a little bit of necrosis, things die off, we got a problem, okay?
Can you get a deep from DVT, like, I know we always talk about legs, but you can get them other places, like arms.
In your arms, I've seen where people have multiple clots here, and they just have a higher risk of developing clots. So say somebody that's a quadriplegic, can they move their arms, can they move their legs, they're sitting in a chair all day, alright, they're gonna have really terrible blood flow.
I just know that we always talk about legs, but we kind of forgot like arms, because they can.
I didn't know what you're called.
Quadriplegic, when they can't move their arms and legs. Paraplegic, when they can't move their legs, something like that. Go. So I kinda went over this already, but our risk factors are that long periods of sitting. So we gotta think about our patients in the hospital setting. Are they, laying in that bed for too long? Okay? We need to get them up and moving as soon as possible. If it's not contraindicated, maybe we need to get physical therapy on board. Okay? Get them up, moving around. Even just doing simple range of motion type exercises. Okay? That can promote that blood flow to occur. Sometimes physical therapy will even offer like little massages and stuff, trying to promote some of that blood flow to occur. What do we put on all our patients when they get to the hospital? SCDs, all right? The sequential compression devices, okay? That helps with blood circulation, helps with that blood flow, because it's kind of massaging that leg, okay? If they've had a previous DVT, they're gonna be at a higher risk for another DVT. That just makes sense, okay? Your product prediction score, that's really takes a lot of these factors into account. And the higher score, higher chance of you're gonna get a DVT. Okay. So on our physical exam, when we come in, what are we gonna see from our patients? We're gonna see a unilateral leg swelling, okay? That redness is gonna be a little bit of warmth to it as well. They're gonna complain about pain in one calf or another, okay? So we're gonna do a couple different things. The best method is gonna be that venous duplex ultrasonograph. Okay? That's a big fancy term for we're just gonna Doppler the blood flow within our extremities or wherever we think the clot may be. So if someone comes in with right leg pain and swelling, we wanna roll out a DVT, we're gonna do an ultrasound and see the blood flow through their right leg, okay? And it can show us that clot, okay? MRI, we can use that. Sometimes you can kind of pick up a pretty big clot. Or MRI, a D-dimer as well. Anybody know what a D-dimer is?
Lab value?
It's a lab value, good. That's all we really need to know, okay? We don't really need to know the specifics of what the D-dimer is, how much it's gotta be, okay? What a D-dimer is going to say, potential for a clot, okay? There is a clot somewhere within the body. Doesn't tell us specifically where, it just tells us that's a good indicator that more than likely if it's elevated, then we're gonna have some type of clot within the body, okay? All right. So we'll talk about medications in just a minute. So our non-surgical management, we're gonna continue to do these leg exercises. Initial, acute, if they come in after developing a DVT, we're not going to put on an SCD on that foot, okay? We're not gonna get them up, moving around. Why? We don't want it to move, okay? So remember, they're at a higher risk for an MI or a stroke or PE, okay? So that acute phase, until we get their blood thin enough, we start giving them some medications. We can start infusing some heparin therapy, which we'll talk about in a minute, try to block up that clot. Sometimes we can do some surgical intervention and actually go in and retrieve that clot. And once we do that, then we can encourage our patients to get up and move around, do what they normally do. going on mountain exercise after that, okay? So we talked about SEDs as well, compression stockings. You'll see that sometimes, they'll put those on before surgery, because they're super immobile, during surgery, don't want them to get a clot, within surgery, so. And then we go over to that surgical management side, so the thrombectomy. So again, they're gonna go in through the groin usually, if it's in within the leg, and they're gonna go in and kind of retrieve that clot, just kind of break it up. Sometimes they use lasers, sometimes they'll kind of cut it up. And then sometimes they'll actually leave a catheter in, and we can kind of drip heparin through that catheter line, and then kind of let it drip on that, DVT itself, and on that clot itself. And hopefully kind of break it up a little bit, and also not allow it to kind of build up bigger, on the clot, okay? Because we have a clot, more blood's coming through, that clot wants to grab any other blood cells and form a bigger clot, okay? Inferior vena cava filter, what's that?
It's a little filter that they put in there that when the blood flows through, it collects all the clots.
Good. So where is the inferior vena cava?
At the
Inferior
top.
vena
Top of the.
Going into the heart.
Oh, that wasn't bad.
Yeah. I'm a nurse, I'm not an artist, so. Okay.
The superior is on top and the inferior.
So you got your superior vena cava here, alright? That's dumping blood into our right atrium right here, okay? From the upper half, really, of our, body, okay? Then we also have the inferior vena cava, which is in the lower half, that's collecting all the blood from the lower half of our body, that allows it to dump into the right atrium, so it can circulate back through, within the, chambers of the heart, okay? So we're actually gonna put a filter right through here, okay? We place that filter, as blood flows through, like Anna said, it kind of picks up those clots, anything that's too big to pass through the filter, it collects, and then it allows the blood to flow through, as it should, okay? So somebody that is at a higher risk for a DVT, or producing clots, that's had clots previously, this is something that we can consider for them, inferior vena cava filter. Yes?
These are clots, not clot at the filter.
Every now and then you have to go in there and check it out. It kinda looks like a woven basket almost.
So it's something that's.
Kind of like a blood filter, isn't it, like the one that you use for blood filtration when you give blood?
Similar, yeah.
So it stays in the heart, it's not just when the procedure's done, they keep.
Yeah, they keep it, this, like, it stays in them, right?
So
So you'll see it, and this is not like if they have clots everywhere now, this is like an occasional clot or something that might get collected, okay? So we don't have a PE or an MI or stroke, something like that, okay?
Do the clots dissipate?
It usually just kind of stays in there.
So if I have him right now and have that filter put in, when I'm 90, the clot would still be hanging out?
Should.
So.
Not 100% sure on that, so don't put them in. Yes, Sam?
I'm not understanding, so how do you have all these foreign objects on the body, and have to foreign the body, right, supposed to protect you?
Right.
My body not analyzes.
So it is attacking it, and it's trying to, have some type of clotting factor, that occurs. So, when we have some type of